Hello and welcome to the EduTalk series hosted by Biotone EduPartner Program, and massage industry experts. Though we've come through the worst of COVID, there are challenges still facing massage schools, students, and practicing therapists. The EduTalk series continues to support virtual learning and connecting you with industry experts who share their knowledge and expertise on topics not only for class discussion, but career success. Tonight's expert is James Waslaski, educator and international lecturer, teaching wellness and healthcare professionals how to integrate their techniques to increase client outcomes. James is author of a well-known textbook, Clinical Massage Therapy, a Structural Approach to Pain. He's NCB TMB approved and a certified professional trainer with the National Academy of Sports Medicine. James is the recipient of numerous massage industry awards and was inducted into the Massage Therapy Hall of Fame in 2008. Let's listen and learn as James discusses integrated manual therapy for low back pain, hip pain, and sciatica, reviewing the clinical approach to assessing and treating the lumbar, spine, hip, and pelvis, addressing low back pain, SI joint dysfunction, iliosacral torsions, lumbar compression, and bulging or ruptured disc pain. So buckle up, we've got a lot to cover tonight. Thank you for joining us. And please be sure you are muted and your video is off. James would love to answer your questions, so please use the chat button at the bottom of the screen to submit questions, which James will answer at the end of his presentation. And with that, I turn it over to you, James, and thank you for joining us tonight.
You're welcome, Danielle. It's an honor. I've known you for so many years, so I'm excited about presenting tonight. I'm going to bring up my PowerPoint and share that. And here we go. So it's an honor to be here. Since March of 2020, I have done about 100 and some Zoom classes, and I reshot all my handouts, which Danelle is gracious enough to be sending you a copy. I believe tomorrow they'll be sending you a copy of the handouts, which are basically going to follow the pictures that you're going to see here in the PowerPoint presentation. So the timing is really quite amazing. My wife was suffering from what I'm going to show you. I've got teaching models I'm going to be using, but her disc is, if you look at the disc in front, a disc in the middle, and you look at this, here's what's going on with my wife's back right now. I'm going to squeeze that out. So that disc is bulging out like that in her back. And when we go to the big screen, you're going to get to see how I'm treating that so that she doesn't have to have disc surgery. So one of the things we're going to look at today is we're going to first look at the iliums, and I'm going to be bringing again teaching models in the big screen as well as on the lecture. But I've studied with, 15 times now with Dr. Eric Dalton. I've studied with him in Costa Rica 3 times, in Oklahoma a bunch of times. And one of the things Eric taught me is about the spinal engine of the ilium. And so I want to keep this simple. I know some of you are students and some of you are veteran therapists, but I want to talk about the right ilium and the left ilium and in the middle of the sacrum. That's all I want to start with right now. And I want to talk about an iliosacral torsion, which is when one rotates anterior or posterior, which is very common when people have SI joint pain. So one of the things I start with when I get a client with back pain is I want to check where the iliums are at. So we'll be demonstrating basically how to find the AIIS or the ASIS, the front of the ilium, which means if you want to keep it simple, go all the way around that same ilium, and the back of that same ilium is the PSIS. So what I do before I teach any techniques is I explain bony landmarks. That's going to be important when we get into this presentation. Now, this presentation will look at chronic and acute low back pain. And I'm going to show you some acute injuries that in these photographs that need to be treated right away. And I'll tell you why I was hit by a pickup truck on my bike last July, and I'll show you some slides of the acute injury and the femoral nerve damage and the low back problems I was having. But I'm perfectly fine now. I'm back on my bike. I'm really doing great. But I want to also talk about some revolutionary hip capsular adhesions or hip hydration techniques, which will allow the femoral head to move more effectively and freer within the socket of the ilium. I want to talk about that this afternoon. And I also want to talk about bulging disc, herniated disc, ruptured disc, ligament pain. Last fall, Robert Libby asked me to review his book on ligament pain, and I realized that we don't have an SI joint sprain. We typically have an SI joint torsion. And when the iliums get rotated and out of synchronization around the sacrum deviates, so we get an unlevel sacral base, and the ligaments that hold the bones together. So now we got bones that can move out of alignment. We've got ligaments that can be twisted, and they refer like trigger points if they're twisted. And then we got the muscles and the soft tissue we're going to talk about today too. And I want to talk about balancing the muscles. Really important is that I teach up until 220, I was teaching 4 chiropractic conferences a year. And I would tell the doctors, I'd say, if you treat an iliosacral upslip, which is where you got to get the ilium to slip back down, or if the doctor of chiropractic medicine treats an iliosacral torsion, then you must also free up the joint capsule of the hip, and you must also balance the muscles around the hip. So now I'm integrating what we do best as massage therapists, which is muscle releasing tight muscles, activating and strengthening weak muscles to create balance around joints. And then I'm combining it with the chiropractor would do, which would be get the bones lined up. And we're going to show you how to, through relaxation of ligaments and through position release techniques, we're going to show you how to get those iliums moving better around the sacrum, getting those muscles balanced, getting rid of bad scar tissue, and restoring normal muscle firing patterns in the hip. Now, this is a look at the spine. And I just had a pretty world-renowned chiropractor in my 5-day here in Dallas, just this past week. It was the past Wednesday through Sunday. And he said that most of his clients walk around with disc degeneration, and they're relatively benign. So I want to explain normal discs and bulging discs, and also I want to explain normal lumbar curve. So if you look at this segment, we have the ilium. Now, first of all, those lumbar spine, they have to sit on a level sacral base. So here's the iliums, here's the sacrum in the middle. And if the iliums are out of alignment, the sacrum goes uneven. And degeneration, I mean, I'm turning 65 in a month. And degeneration doesn't happen over time. I don't have any joint pain. I don't ever believe when a chiropractor says degenerative arthritis is a natural process of aging. Because if degenerative arthritis was a natural process of aging, I'd have joint pain all over the place turning 65 years old. I don't have any joint pain. I cycle every day. I'm in the gym every day. I told my wife yesterday, I want to be like Jack LaLanne. I want to be in my 80s and moving. But my wife and I do spinal decompression techniques. My wife and I get regular adjustments. We get good body work. We do maintenance. So with both of us being in our 60s, we do maintenance. So we don't have joint pain. We don't have degeneration. We don't have the wear and tear that happens when the spine is out of alignment, or we don't have an excessive lordotic curve, or, so the normal lumbar curve, as you're seeing here, is what our goal is going to be. And we have to know how to restore that, because some people are going to come in with a flat back and some people are going to come with an excessive lordosis. And that's dependent on muscle imbalances. And that's dependent on things like leg length discrepancies. And that's also dependent on what those iliums are doing. And if the iliums are rotating out of alignment, then the sacrum is out of alignment, then the disc curve and the disc bulges occur. So in this photograph on the bottom, and this is a weird photograph because usually on the bottom, which is L4, L5, that's where the most degeneration goes on, L3, L4, L5, S1. But then this graphic artist decided to show a normal disc on the bottom, disc degeneration with osteophytes just above that. That means there's bone spurs forming because the fluid got dehydrated and the disc starts to degenerate. Then due to compression forces, say the pull of the psoas, the overactive QLs, what happens is we can get rotoscoliosis of the lumbar spine, we can get excessive lordotic curves, we can get a flat back, and that's the way it's going to push the disc out. So an example I showed earlier is my wife has a flat back, and when she goes into flexion, this happens. So when she goes into flexion, that fluid spills out, and that comes from flexion. So we need to understand what's going on with this lordotic curve to neutralize. I have to do certain things. There's certain positions I can put her spine in that pushes the fluid out, and there's certain positions I can push it in. And when I teach, I'm a very visual person. My stepdaughter Alex is really responsible for me as a great educator, because through the struggles she went through with her autism and her dyslexia, she said, why don't teachers teach the way I learn information? And Alex said, why don't they show visuals like you do with all the skeletons, the bones, the muscles, the charts? And why don't they combine the visual and the kinesthetic? So while the student is looking at a picture, they're seeing a technique. So the technique coordinates with the picture, and that's how I teach. And it's kind of cool because I'll always use one slide that shows the picture, which you're going to see in some of these PowerPoints coming up. Oh, let's go back to the slide. So what my wife has is the bulge. If you look at the one that says a bulging disc, and her pain is unbearable when that fluid spills out like that on these nerve roots back here. But her pain is controlled and stable when we don't have that fluid spilling out. We're going to show you some biomechanical things to do as a massage therapist to correct that. So when we get into, this was my hip replacement, and why would that affect back pain? I had a hip replacement in 2015. So I took a picture of it. I took a photograph right when I came out of surgery, and that left photograph is why they call it gross anatomy. I like to add a little humor to it. But as soon as I got that incision, I started to do microcurrent and cupping. Microcurrent changes the scar at a cellular level by changing the ATP, increasing ATP to the scar, and it makes the scar softer and more malleable. And then I studied with Anita Shannon, and she said with therapies, cupping are antioxidants, neuromodulators, and basically anti-inflammatory. So with the inflammation, what I did before my hip replacement is I had lymphatic drainage done, and I had cupping done, and I had the techniques that I'm going to talk about tonight done. That was the night before surgery. Then after surgery, I've trained with Dr. Kerry D'Ambrosia here in Dallas. I took a 4-day workshop on total body lymphatic drainage. In fact, I'll be in his class tomorrow. I'll be in his class in Florida on lymphatic drainage again, because lymphatic drainage actually before and after surgical procedures gets all the inflammation and the metabolic waste out of the tissue so that new blood and oxygen can come in. So we have a whole course on prehab and rehab for hip replacements. And when I go to the big screen, I'll show you that I can move my hip like a 15-year-old. I can move my hip all over the place, no pain. In fact, I forget which hip was replaced. So this slide on the left and the one on the right goes from a scar that looks like a Frankenstein scar to a scar that looks like a pencil line to now a non-visible scar, because I have a very functional scar from that. And that affects hip and back pain. I talked about I was hit by a drunk driver on my bicycle July 9th of this past year. And this is really an interesting photograph. The first slide was where the handlebar went into my leg in my femur. Then that damaged my femoral nerve, which innervates the quadriceps. So I was having some numbness and tingling and paresthesia, pins and needles into my toes in the emergency room. And when I got home, I'm going to be seeing Kelly Armstrong this weekend in St. Augustine, Florida. But I called Kelly Armstrong from the emergency room and I said, Kelly, I have a pretty nasty scar in my leg, and my nerve underneath, the femoral nerve is involved, and I can't feel my toes very much, and I can't wiggle my toes very much, and I need your help. So Kelly got on Zoom, which is where we are now, and Kelly walked me through the use of the microcurrent. So the third slide shows me using microcurrent and driving. It's the opposite of a TENS unit. I'm driving, increasing ATP, increasing metabolism, and increasing changes of the matrix of the scar tissue. And the second image from your left is when I was in the emergency room. I took a picture after they stitched it up. The third image where I'm looking at using microcurrent is literally 1 week post-injury, and look at the difference of the inflammation and the scar matrix. And between lymphatic drainage, which was getting fluid out, allowing the fluid to move out of the area, and fresh blood in, the emergency room doctor, when she took my stitches out, she said, I've never seen a scar heal that fast. And then about 3 weeks in, I I called Anita Shannon because I have them in my speed dial. And I said, I need to know when I can start actually doing cupping directly over the wound site. And then the last slide is about 23, 24 days later. And then I just started doing some nerve flossing technique, which I teach in my nerve classes. And long story short, within a month, no numbness, no tingling, no paresthesia, no pins and needles. And why does this affect back pain? Because these scars left dysfunctional, especially in that quadricep, these scars left dysfunctional, pull your ilium down and forward. These scars that your doctors don't tell you about are just like tight muscles. They have fascial lines of tension, and they affect the joints, and they affect the lymphatic system. And they're pretty amazing that you have to treat those so that the joint function can be more effective, and that the nerves underneath of there can be more functional. So the universe, sadly, but yet gracefully, gave me an opportunity to learn how to treat scar tissue more effectively. I'm back cycling, running, working out in the gym every day. My wife said to me, she goes, when you have trauma, you really step it up and you really heal well. But maybe some of the men can relate to the next statement. But she said, trauma, you really step it up and heal well. But when you have a little cold, you're kind of a little whiny about it. And maybe that's just a guy thing. But I recover. And because of that, now I have better treatments for my patients. So I'll go to the next slide here. Now, inside the hip, inside the ball and socket joint, so where the femur sits inside the ilium, there's synovial fluid, and then there's a joint capsule that surrounds that hip. And when you sit a lot, adhesions can form in the anterior capsule of the hip. So fascial adhesions can form. And then if you add a secondary scar, like you saw with my hip surgery, then that pulls the ilium to these fascial lines of tension. So lack of fluid in the joint capsule can prevent rotation of the femur. And we know that the femur should flex independent of the ilium, extend, flex. It should abduct and adduct. But if there's a scar in the tissue, or if there's a dehydrated joint capsule or myofascial lesions in the hip, then rotation of the femur within the ilium drags the ilium with it. And if the ilium drags with the femur, then we get things like iliosacral torsions, and now we have SI joint pain. So everything's connected. We have to see what are the two iliums doing around the sacrum? What's going inside the socket? Is there enough synovial fluid, and are there adhesions in the capsule? And how do we treat those? We'll show you in this presentation. And we have to do positional release. Now, I noticed Volker, Captain Alaska, is on here, and Volker brought me out to Alaska, and I taught many years ago. Now, Volker, what I taught you, if it's more than 2 years old, it's a little bit outdated now. So instead of going in like we taught years ago in Alaska, we would go in and do this mortar and pestle thing. I don't do that anymore. Instead, because of a study posted by John Sharkey, and it was actually posted about frozen shoulders, I apply that study to hip capsular lesions. So what I do now, if you have an injury, say an adductor strain, or you have a scar from a hip replacement, or if you have dehydrated, not a lot of fluid in your capsule from lack of movement, is if you look at the slide on the left, I first, when you're supine, I assess internal and external rotation. That means that when you're standing, the femur should medially and laterally rotate. And there should be a balance between, if you look at the slide on the left, we should have 45 degrees of internal rotation where the femur moves towards the midline. And it should be a soft infill. If it's a muscle pattern, if it's the deep six and it's a muscle pattern, then that assessment you're seeing on the left, where I'm rotating Fran's foot away from the midline or femur towards the midline, that internal rotation that's supposed to be 45 degrees should be a soft infill. It should be a muscle pattern. But sometimes when you try to bring that leg out, it feels like bone's hitting bone. It feels like a hard infill. If you find a restriction in rotation of the hip and there's this hard infill, again, look at any surgical scar tissue patterns, but mostly what you're going to do is you're going to learn to gently compress the capsule and pull fluid into the capsule and compress the capsule. Think about using the femoral head to relax the tissue and stretch the tissue, and that creates some hydration. What brings fluid into a joint is joint movement. So when we don't have movement, the adhesions and the dehydration of that capsule needs us to do positional release and stretch the capsule. And that's going to increase motion of the femur independent of the ilium. And why that's important is that the femur is not moving independent of the ilium. The femur is dragging the ilium with it. It's going to create torsion. So let's talk about a torsion. Ilium, sacrum, ilium. In one ilium goes anterior, one goes posterior. It actually twists the ligaments around the sacrum, which is called articular ligamentous torsion. And then the ligaments refer. But what's worse is when one ilium goes anterior, one goes posterior, it unlevels the sacral base. And when there's an unleveled sacral base, it has to develop a sliding component on that disc can happen, and rotoscoliosis and scoliosis of the lumbar and thoracic spine can occur because we have a spine that's not sitting. If this spine, and I'm going to show this whole spine is not sitting on a level sacral base, it's going to start to have to rotate and side bend to cause what Fran's got now is that bulging disc. And that's because she had an iliosacral torsion and she was born with a leg length discrepancy, and that unlevel sacrum was the reason that the degeneration moved into L3, L4, L5, S1. And she has a sacralization, which is a genetic pattern where there's a little bit of a fusion of one ilium around the sacrum. And what that means is when you're walking, the iliums are supposed to be moving around the sacrum like that, but with a sacralization, there's a fusion. So you only get really movement in one ilium, which if you look at that again, unlevel sacral base. So you're going to have bulges and ruptures and herniations and things if you don't have the iliums moving gently around the sacrum. Now, I know you're saying, but we're massage therapists. Scope of practice. I really, really, really respect scope of practice. So when I study with Robert Libby in Canada, Robert Libby is a world leader in articular ligamentous referral pain patterns. And when I study with Robert Libby, he said when one ilium rotates anterior, one posterior, and it gets stuck in this fixated state, the ligaments are twisted. They're not sprained, they're just twisted. And when the ligaments get torsion or twisting, it causes them to refer. So there's your SI joint pain. And now what we do is if we have a client on the table with an iliosacral torsion, we pull the iliums out from the front, which is called an out flare. So we're relaxed ligaments. Then we do an in flare and an out flare, and it really starts to increase a little bit of the SI joint pain. So the movement can come back and we can guide those iliums to where they're even. So there is no high velocity or joint mobilization required. It's really just relaxing ligaments so that the iliums can move better around the sacrum. And then what we'll demonstrate is that I get the iliums to come out and in and out and in, and then I get them to rotate around so I restore what's called your spinal engine. When you're walking really doesn't come from the legs extending. Walking comes from the iliums having 5 millimeters of rotation around the sacrum. So this is your spinal engine. And when you lose that movement of the iliums around the sacrum, which we can restore by relaxing ligaments, called positional release of the articular ligaments, we can restore that through good manual therapy techniques, and we don't have to ever force the iliums to move, and we're not supposed to in it because that's the chiropractor's job. And we can achieve the outcomes they can achieve by relaxing ligaments to improve joint function. We'll talk about that. So one of the first things I do when you have back pain is I put my fingers on the notch and I just see if you're even. So let's say Fran's on the table and I put the fingers on the notch. You could be rotated this way from a foot problem. You could be rotated this way from a iliosacral torsion problem. And now why is that a problem? Let's look at this right ilium. When this right ilium goes anterior, say you sleep side lying and your iliacus gets tight, which is the muscle in here, and your rectus fem gets tight. If the ilium goes anterior, what it does is it makes the psoas on that same side a long, weak spinal stabilizer. So if we don't assess the ASIS or AIIS, and if we don't relax the ligaments and give the ligaments a little bit of nutrients, what gives ligaments nutrients is joint movement. And this is very subtle. Therapists are just pulling these apart and relaxing and stretching and relaxing. And this joint movement gets nutrients to the ligaments around the sacrum, and then that allows the motion to come back easier without forced movement of those joints. So when you're in my classroom and what we have you do is we have you check those landmarks. And then what we have you do, if you see your hands, Now you don't want to, in that second picture, you don't want to press down into the table. In that second picture, what you want to do with your hands is you want to kind of cup the ilium like this, where your thenar eminence is on the inside, and you want to just push out. So if you look at that second image, my thenar eminence is on the inside of this bowl called the ilium. And my thenar eminence is basically pulling the iliums a little, just real light. It's so light. And they'll say, that feels good around my SI, because what it's doing when you gently pull those iliums apart, you're relaxing the ligaments in the back that attach the ilium. It's called positional release of the ligaments. And when you relax the ligaments don't refer as much. Ligaments refer like trigger points when they're sheared or torsioned. And then when you put your hands on the outside of the iliums, like in the third slide, you're just pushing the iliums in a little bit. And as you're pushing the iliums in a little bit, what you're doing is you're getting a little bit of movement around that sacrum so that this can happen. And then you're asking the client, hey, when I push your iliums in, can you put your hands on my hands and help me push? And then we push the iliums, and we're going to get a little bit stretch on the ligaments in the back, and that's going to restore movement. And then we'll get you moving with us like this, and we'll put you where you're even. If you're even in the back, keep it simple, you're even in the front. This bone, this ilium, goes all the way to the back. And so whatever we do in the front, we're doing in the back. It's just the same bone. So think about if it's anterior in the front, it's superior in the back. So when we relax ligaments, and this is in the scope of practice of massage because it's called positional release of the articular ligaments, and we give a little bit of a ligament a stretch because they have eccentric load, they don't have contractile abilities. And then we restore the movement that's necessary for those ligaments to get nutrients so they don't refer, and then you don't have SI joint pain. Keep in mind, I teach osteopaths in the UK, I teach chiropractors in the US, but you know what I teach them? That we are the muscle experts, that massage therapists are instrumental to restoring muscle balance to improve and maintain joint function. So I'm a big spokesperson for this profession called massage therapy because if we don't help the chiropractors, if they just adjust the joints, and some of them do, some of them are great chiropractors, some of them are old school rack and crack type of chiropractors. If they just do an adjustment, but they don't restore muscle balance and normal muscle firing patterns, and I'm a personal trainer specializing in corrective exercises. So if I don't tell you to stretch what's tight and strengthen what's weak, then the therapies we do and the adjustments that our colleagues do don't hold, because you go back to old sleeping patterns, you go back to old sitting patterns, you go back to different things that brings the postural distortions back into the body. So I don't tell someone I can fix them. I tell them that I'm going to get their joints and their ligaments and their muscles healthy and balanced. And when I get their joints and ligaments and muscles healthy and balanced, then the exercises I will then give them will be customized precisely to keep the tight muscles stretched out, the weak muscles activated and stimulated and strengthened. And that balance, see, when you put the body into balance, the body has the innate wisdom to heal itself. So I don't fix you. After 21 years of marriage, and those of you who've known me over the years, Fran, the beautiful wife Fran I have is in all these photographs. She has taught me the importance of humility. And when you get your ego out of the picture, and you get the ego out of the hands-on treatment, and you come from a place of love and compassion and intention to facilitate change, and then you just guide the patient to a place of balance without forcing things to happen, without the ego thinking I fixed them, things change. And especially now with COVID, people really need kind words. And I don't point out pathologies that are negative. Whitney Lowe talks about this. Whitney Lowe, he changed my whole career actually. In 1993, Whitney Lowe taught me the importance of good orthopedic assessment and clinical reasoning. We've done multiple Zooms this past year together internationally. And without Whitney coming into my life in 1993 and teaching me orthopedic assessment for massage therapists, I didn't always do the right technique. So every technique I teach now starts and finishes with assessment. If the bones need to move a little bit, that's my technique. If the muscles are tight, I lengthen them. If the muscles are weak, I activate them. But every technique I do starts and finishes with assessment. And I want to give credit to my friend and colleague, Whitney Lowe, Orthopedic Assessment for Massage Therapists. Great book, by the way, if you get a chance to see it. Now, Psoas work, I have heard some horror stories about how painful that has been in manual therapy. why I'm concerned about inflicting pain. And I'm a big spokesman of not causing pain, right? Because if you dive in there between the iliacus and psoas, I don't know if y'all know this, but in this space between iliacus and psoas, in this space is the femoral nerve. And if you just dive in there into that femoral nerve, it's going to cause the muscles to tighten. So if you have to work the psoas, because as you see in that second image, and in this one, it attaches to the lumbar spine. It's not a rotational muscle of the ilium, that's the iliacus. The psoas can either put compression or load on the spine if it's tight, or it can allow extra mobility if the psoas is weak. And if one ilium is rotated anterior, that psoas becomes weak. So you're not always just wanting to go in and dig on those muscles and stretch them, because sometimes due to the iliosacral torsions, there's a weak spinal stabilizer. And we want to get those iliums balanced so that that psoas is balanced. And then we want to assess how to treat that psoas. Now, if you're going to treat the psoas, what you've got to do is you've got to make sure that you loosen up the edges of the rectus abdominis a little bit between the obliques, so you don't have to dive through those superficial muscles. Then all you got to do is just gently keep your fingers straight. Like you look in this psoas release technique, I'm basically entering iliacus and working that. And then I'm going in at a degree where I go under the pelvic abdominal organs onto that psoas muscle that you're seeing in the second image. If I'm on the psoas, I don't want to be poking on it with my fingertips. I want to be on it with my finger pads. So when you get into the psoas and you're poking on it with your fingertips, it can cause pain. And when you pinch a muscle, it tightens. And when it tightens, it puts extra load on the discs and the lumbar spine. So creating pain in psoas work is something I highly don't agree with. So I'm going to go in, I'm going to just slide in there gently. I'm going to work with your breath. I'm going to just go in there progressively and gently. And when I'm on it, I'm going to have you just rotate your femur back and forth as I apply pressure with my finger pads. And because the psoas is not just a hip flexor, it's a lateral rotator of the hip. So as I gently wait for that psoas to soften, and instead of forcing it to tighten, I get such better results. And then if you have a rotated ilium, I just go in and work your iliacus, this little muscle inside here, just in the inside here. And I don't use my fingertips, I use my finger pads. It's a real gentle massage of the iliacus to allow the ilium to come out of rotation. So muscles pull bones onto nerves and blood vessels. And when the bones rotate out of alignment, it twists the ligaments, and then the ligaments refer, and then the muscles tighten. And then the person that goes in and attacks the psoas makes the muscles tighten more. It took me 30 years. I was a paramedic firefighter for 20 years prior to massage, working in a trauma center. I was pre-med for 3.5 years, and it took me 30 years of manual therapy to really lighten my touch for the psoas work. So we'll go to the next slide. Just to kind of share a little case study I had. I was teaching the Florida Chiropractic Physician Conference, and I teach them massage because they don't. I was serving on the board of Parker Chiropractic here in Dallas. I was a consultant, and I was saying, I wish that the curriculum would include more soft tissue therapy. And I wish that they would become certified personal trainers so that the clients could be taught to stretch tight muscles and strengthen weak muscles. And a chiropractor had a femoral nerve. If you look at the slide on the left, it says femoral nerve pathway. Now, if you look at that femoral nerve, do you see why I don't want massage therapists diving into that space, onto that femoral nerve? Because that femoral nerve innervates down into the quadriceps. And that femoral nerve doesn't like being poked on when it's already trapped. And what had happened is the chiropractor that I treated had torn the psoas. He was water skiing, and his ski went under and it extended his leg. So totally pulled that femur into rapid extension, and it tore the distal end of his psoas. So look at where the femoral nerve is, where the tear is. So he had scarring all over the distal end of the psoas. And what had happened is this nerve, like my little finger in here, was scarred down by a strain. And anytime somebody tried to stretch it, it got worse. So he'd had 12 years of femoral nerve pain. And all we did is we gently pulled the ilium away from the scar. We worked the psoas. We did some microcurrent and some frictioning, and we did some concentric. We created a functional scar. Then I have a whole course on nerve release. We had him do some nerve flossing. He went prone and he used the femoral nerve like a piece of dental floss to now free it up from where it was scarred down. And long story short, he couldn't even walk on his own accord when he got on my table. And he was running up and down in the chiropractor, and there were 200 chiropractors watching. And I tell you what, they have never had so much respect for soft tissue specialists like massage therapists. And they said, we didn't think about I talked to a number of the chiropractors. We didn't think about the scarring of that femoral nerve. We were looking more at bones on the nerve, ligaments on the nerve. So the massage therapists are the special for treating soft tissues. And that's what I love is we can free up nerve pain, ligament pain. We can balance joints better through good soft tissue rebalancing techniques. And then a couple more slides here. If you look at the rectus fem, I used to teach sports massage. In fact, I was just talking to a gymnast that was here visiting my daughter, and he knew that I had worked the 1996 Olympics with the Olympic gymnastic teams, all the teams from all over the world. And one of the things I found is that if we lift and separate rectus fem from the femoral nerve, and that allows the femoral nerve to function better. So I used to always do compression to the quads in sports massage. But now I lift and separate rectus fem. I lift and separate the IT band and I do cupping or vacuum therapies on the rectus fem to free up the femoral nerve. I do cupping or vacuum therapies on the IT bands. I learned those techniques from Anita Shannon and ACE cupping. It was really kind of a cool experience. Now, a few more slides left, and I'll go with the Q&A with Danelle. When they're prone, a lot of the times what concerns me, I was at the fitness center the other day and I saw a trainer trying to raise the leg into extension, and I watched them, and what they did is they actually did this as the leg went back, the ilium went forward. So while they were trying to stretch the psoas, they were creating an iliosacral torsion. I thought, and the guy on the table was going, that hurts my SI. And sadly, the trainer, who must have been a rookie, he said, no pain, no gain. And I disagree with that. I disagree with that statement in body work. I disagree. Usually a pain is a signal that the underlying pathology is getting worse. So there's certain techniques you can do with my wife's back that will compress that disc worse. And there's certain techniques you can do with my wife's back that will recess that bulge. So the way that we treat the lumbar curve and the way we level the sacral base has to do with what kind of bulge do they have. Sometimes you don't want to stretch the psoas because it's a weak muscle because of sacral torsions. So we have to assess, back to Whitney Lowe. If I don't assess, I'm just guessing what I'm supposed to do next. So what I usually do when I want to stretch your hip flexors is I first do the technique on the left-hand image. All I do is I put my hand below the ischial tuberosity and my other hand under the knee with a knee bend. I only pick up the knee an inch. I'm not trying to stretch the psoas. I'm trying to drive with my hand if you look at that first slide, with my hand here, I'm trying to push the femoral head anterior into that joint capsule to stretch the iliofemoral ligament, to hydrate the joint capsule. I'm trying to push fluid into the capsule, and I'm trying to stretch the ligament that holds the ilium so that the femur can move free and independent of the ilium. Then what I'm doing in the second slide is I'm stabilizing the ilium. So when the leg goes into extension, the ilium doesn't go into flexion into the table. So you only want the leg to go into extension when you stretch the psoas. You don't want the ilium to go into flexion, because if the ilium goes into flexion, you create an iliosacral torsion. Now you just unleveled the sacral base. Now that we have this up there, an unleveled sacral base will shear the sacrum towards the sciatic nerve. So it's not necessarily, very rarely is the piriformis the cause of sciatica, even though I learned that from Travell's work and neuromuscular work. Usually in iliosacral torsion, there's pressure of that sacrum on that sciatic nerve. There's overloading of the articular ligaments. The iliosacral ligaments get long on one side and short on one side. And if we as massage therapists don't get that ilium neutral by relaxing ligaments, stretching ligaments, relax, you don't want this going on. Because I had a woman, she had sciatica for 12 years. It was this sacral edge pressing on her sciatic nerve because she had one ilium anteriorly, she had an iliosacral torsion. Again, massage therapists can relax ligaments, stretch ligaments, relax ligaments, stretch ligaments. get those iliums moving and put that sacral base level. And then you have a balanced piriformis. You have a non-torsion sacrotuberous ligament, and you can do better work. Third slide, muscle firing patterns. When I walk, what should fire first when my leg goes back? When I extend my femur to push me forward in walking gait, what should fire first are my hamstrings and my glutes, not my QLs. But right now I'm sitting, right? And you're probably sitting. And when you sit, your brain tells your glutes to become inhibited. Otherwise, the glutes would fire back against the hip flexors. So from chronic sitting and from chronic sleeping inflection, the gluteus maximus becomes neurologically inhibited. So it's a brain thing. And then when you go to pick something up, instead of your glutes and hamstrings working, it's your hamstrings and your QLs. So when I test muscle firing patterns, and I have my left finger, my left hand is on the hamstrings, my left thumb in that picture is on the glute max, and then I'm checking both QLs. And usually when I say, can you slowly raise your leg up, you'll feel the QLs firing right away, which means they're overactive. So in massage, you can rub the QLs over you want, but unless you activate the glutes, unless the glutes are doing their job, the QLs are always overactive. And a majority of the bulging disc, spinal stenosis, disc degeneration, herniations, and ruptures, they're not coming from the QLs that are overactive and tight, and they won't let go if you rub them, but they will chill out if you activate the glutes. So Eric Dalton said it so well. I've studied with him like 12 different years, and I'm teaching assistant for him at July 2nd through the 4th. We're teaching together in Oklahoma. And Eric Dalton said it so brilliant. He said, if the back hurts, it's the butt's fault, which he was referring, of course, to gluteus maximus. If the back hurts, it's the butt's fault. So what's happening is from sitting and driving and sleeping in flexion, the glutes are turning down their volume of firing. So when you go to stand up, instead of the glutes and hamstrings standing you up or to pick something up or to move you forward, it's QLs and hamstrings. And so we have to test and then activate those glutes it's a rapid pace spindle cell technique. It activates the glutes. And if you notice the fourth image, they have to be on a stretch. So if the glute is on a stretch, gluteus max on a stretch with the foot off the table and the femur immediately rotated, then on a stretch, you can take your hands and do this fast paced spindle cell work. Not like Muhammad Ali, but just more edges of the glutes, activation of the glutes, and it irritates the nervous system. So the brain goes, okay, wake up, guys. Now when Mr. Waslaski picks something up, instead of it being the QL, let's have the glutes help him stand up. So you might have experienced this. If you sleep in flexion all night long and you go to stand up in the morning and you go, God, my back hurts so much, I must be getting old. That doesn't happen to me. And I'm the new middle age. I mean, 65 is the new middle age. I don't have back pain when I stand up, because when I stand up, it's my glutes and hamstrings because of the activation and the exercises that I do to keep them active. Now, this is simple for massage therapists. You walk in the room and one glute is lower in the massage table. So you're either looking from the head or you're looking from the foot. One glute is slightly lower, and that means one ilium is slightly anterior. So if you look at the slide on the left, you're palpating the PSIS. It's slightly higher and it's anterior. It's anterior and elevated. So all you do is you go under that side that's pushing down, you go under it and they push down and you rotate it back. It's a muscle energy technique. So it's so simple. It's so simple to correct an iliosacral torsion so that the PSIS is even. It's so simple to do it. So you find that second image, the right PSI is higher. You go under the side that's rotated into the table, like you're seeing in the third slide. They just push down into your hand just gently. And then you just gently rotate that ilium back, and it takes the twisting out of the ligaments. So this one step that you're seeing in these pictures, and by the way, all my Zooms and all of my PowerPoints, all 13 classes were redone in 220. So all we're doing is this person's got bulging disc, SI joint pain, and sciatica. And all we're doing is taking that side that's pulled towards me and we're gently lifting it back in that third image. It levels the sacral base. It relaxes the ligaments around the sacrum. It takes the sacrum, which is sheared towards the sciatic nerve on one side, off of that space. And it just feels so good. They go, oh, my SI joint pain feels better. My bulges aren't as compressed and twisted. My sciatica has gone away. Simple technique sometimes. Then just decompress the back and balance out the internal and external hip rotators. Sometimes balancing out the internal and external hip rotators, because if you're walking with your femur turn out, the femoral head is going to wear out the socket of the hip. If you're walking pigeon-toed, the femoral head is rounded in, it's going to wear out the socket of the hip. But if you balance out the lateral and medial hip rotators, then the femoral head, when it's moving back and forth, it's not rotated off to one side. When you're pigeon-toed, it's got unnecessary wear and tear. Centralization of the femoral head means it's in neutral when it moves. And so by balancing out the internal and external hip rotators, doing good massage therapy, you can centralize the femoral head, and the movement doesn't cause wear and tear that leads to a hip replacement. Now, this technique is only done if you have excessive lordosis. If you have excessive lordosis, I lie them on their side, and that's an increased lordotic curve, too much curve in your lower lumbar spine. And that extra lordosis can be reduced if you lie them on their side. And first, if you're in my class, I would have you check for a sacral pump. If you've done cranial sacral therapy, when you breathe, there should be a sacral pump in between the sacrum and the ilium. And if you're a student, please don't get overwhelmed with this presentation. What I'm trying to encourage is your potential in this profession. I'm trying to encourage that you can work like a doctor. You don't need an MD degree or a DC degree. You can work like a physician. In fact, I want to turn massage therapy into the future of manual medicine. They call us before they even think about surgery. So don't get overwhelmed. It took me a lot of years to figure out all these pieces, and I don't teach this fast in a live workshop. This is actually a full 8-hour class when you're in my classroom, because you're doing all these techniques. So what you're doing is you're just checking the sacral pump. When you're breathing, that's what's getting, that sacral pump is what's getting nutrients to those ligaments. And if the sacrum's stuck in flexion or extension, the nutrients are not getting the ligaments around the SI are not getting nutrients, and the discs aren't getting hydrated. So we actually decompress the sacrum. If there's a jamming of L5S1, we decompress each disc space in there. And all I do is I put them on their side. The knees are up against my hips. My hands basically around the sacrum, decompressing the L5, L4, L3 segments, and trying to restore a lesser excessive lordosis. But with my wife, and I want to finish with this because she was considering surgery, and seriously was considering surgery. Because of the sacralization, where one of her limbs was genetically fused since birth, and the leg length discrepancy that caused, she had, last year, she was ballroom dancing, she was doing the tango, and she couldn't extend, so she had to give up ballroom dance. And she was competing in the tango, and that's hard to give up when you've been dancing all your life. So my wife had this, I bought this image just to mimic what she has. In our advanced courses, what we're going to teach you is how to take this disc, which is bulging out like that, watch again, and get that disc leveled so the fluid spilling out on these nerve roots won't cause sciatica down your leg. My wife has been my best teacher because she's had a lot of back challenges that didn't respond to traditional manual therapy. Leg length discrepancies, sacral fusion, she's had, but she's doing pretty well now. So with my wife, I have to do something. I just want to explain with my wife's back. My wife's got a flat back. So with her, I have to get the disc, the normal lumbar curve back. So it's a different technique than what you're seeing on this slide. And sometimes I have to press the ilium one way, and I have to take the rib cage and shift it the other way. So it pushes this fluid. So it pushes this fluid off that nerve root. And in many cases, you will save so many people from having the rods and the pins and the fusions and things like that. So I think, Danelle, I kind of exceeded my limits. So let's go to Q&A. I am done with the presentation. I will stop screen sharing here and come to the full screen. And awesome.
Well, thank you, James. We haven't had any questions come in. I think maybe they're stunned like I am. I mean, there was so much information there. And I found it very interesting right at the beginning with you showing the cupping and
Mhm.
integrating cupping, as well as the dolphin, which, what did you call that? Electropulse or
Dolphin, I study,
microcurrent?
I'll be with Kelly Armstrong where you live, and she is one of the researchers on microcurrent and how it affects scar tissue right away when you come out of surgery, or like in my case with the stitches, and that was life changing for me. Yeah, and we're proved to use that in Florida, so we can use it. It's the opposite of a TENS unit. It's the opposite type of electrical current, but it certainly saved my leg and my femoral nerve from having residual damage of.
That was amazing. And, just to see that you use several different techniques to hasten the healing. And I mean, that was amazing to see that. Now, I have a question about the Dolphin products because you were using two.
Mm-hmm. Yep.
Now, can you do that with one of the products as well, or you need it at the same time coming at the injury?
Stimulate shutting down the vagus nerve, which is really going to shut down your pain. I like to have two because you got to drive the current from a biphasic to a negative across that scar. And while I was treating that, I didn't mention my wife was treating my spine because the accident twisted my spine. So she was treating the central nervous system. She was looking at improving nerve function, and I was looking at improving scar function. So because it is approved in Florida, anytime you have a scar, especially a C-section, that's probably the first thing I treat is that scar because it affects organs, lymph, postural patterns, it affects joint pain. A lot of people have C-sections and then a year or two later, they have shoulder and neck pain and it doesn't respond to therapy because the scar of the C-section is pulling everything into the organs and stopping lymph flow. So yeah, they're pretty interesting device.
Well, you are getting lots of praise for tonight's presentation. I don't see any questions that have come in.
Wow.
So, I'd like to quickly mention James will be at the Florida State Massage Therapy Association event this week. And if you are there, definitely track him down and ask him your questions directly. I just thought it was a wealth of information.
And we break it down. I did 13 online Zooms where you actually do a PowerPoint, then you slowly go through just neck or just shoulder or just arm or just hip and back or just knee. And what we would have done next is Fran would have walked in here and I would have showed the treatment at a speed. You could be setting up your table and working with me. And now all 13 of those are approved by NCTMB for CEUs, and they're very inexpensive. I think they were $650. They're now down to $350 for 13 courses, and they are on my website at orthomassage.net. And we reduced because of what's going on at 220. We knocked our prices below half of everything for it. So,
well, that's wonderful. And someone made a comment that they like, aside from all the praise, that they liked how you included ligaments with the joint work. Mm-hmm. So much of the focus is on the muscles.
What I learned during this time that we weren't able to go out and travel and teach, Robert Libby was teaching at the Wilfossil Congress, which is one of the greatest research conferences in the world. And he sent me his book on articular ligament referral pain patterns. And when I first looked at it, I thought, this is a trigger point book. But it wasn't. It was exactly where ligaments refer at the knee or the shoulder or the back or the neck. And when they're twisted, they have radiating pain patterns. And as soon as you line those joints up, all the articular ligament pain goes away. And what I did, Danelle, is I actually, through training in positional release techniques, I thought if I can relax the ligaments and relax the scars, then the nervous system just kind of goes, and then the muscles relax. And then I don't have to work as hard to balance muscle groups. So thank you for noticing the ligament work.
Yeah. I mean, to me, not a therapist, it was so interesting. I mean, the ham bone's connected to the neck bone. I mean, it was just to see how everything works together. And then on top of it, the different techniques that you incorporated. So tonight, viewers and listeners and attendees and everyone that's participated, we will have a handout of James' presentation tomorrow once the recording, yes, a lot of information in it. Once the recording is posted to the website, I will send the link to view the recording again, along with James's PowerPoint presentation. And it looks like live teaching is back. So keep an eye out for events, starting with FSMTA and then Eric Dalton's July 4th workshop. And are you attending AMTA as well?
I am. I'm now teaching every weekend the rest of the year. And what we're doing is we're taking precautions and we're keeping the group sizes small for most of them. So every weekend now I'm back on the road and we're starting to do live conferences again and doing classes every weekend. So on my website, you'll see my schedule every single weekend. I'm booked somewhere around the United States.
Well, let's hope that includes Alaska, because they'd like to see you up there again. So let's see, one last comment. Thanks for all you do, everyone. And this has been a great presentation. Thank you so much, James. We'll see you again soon. Thank you, everyone, for participating. And I'd like to mention that our upcoming EduTalks, June 22nd, is Judith Koch Stapleton, and she's presenting Prenatal Massage, Why Specialized Training Matters. Additionally, we have Candace Hart, July 13th, Utilizing Color Aromatherapy to Support Holistic Wellness. And July 27th, Geraldine Villeneuve, How to Unravel Foot Pain Using Structural Reflexology Techniques. Thank you so much. And have a good evening, everyone. Take care.